Nani, she had breast cancer. My Masi had multiple melanoma. So what test do you think I should get?
Cancer can happen to anyone, everyone.
Irregular periods or spotting in between the periods. But then how do you decide, oh, this is a red flag, I really need to go and get my screening done or something like that?
But these are the families where the women in that family should be more careful and probably start testing themselves even earlier.
So what would be a pattern around periods that I should be worried for a teenager? You know, mammograms make you more prone to get a breast cancer.
वायरस है तो चेक रखो.
I read somewhere that a sexually inactive person got HPV. Is that possible? Every other content piece we see today is about cancer, spreading more fear than information. And that is why I'm here today to speak about cancers that are specific to women. And no, I'm not talking about breast cancer, but some cancers that are less spoken about and really needs to be talked about. That is why I have with me today a gynae oncologist, Dr. SAMAR GUPTE. Hello, doctor.
Hello, glad to be here.
Thank you, doctor. Thank you so much for taking out time. So, doctor, what are gynae cancers?
So first of all, gynecological cancers are cancers that are specific to women, obviously, and they are cancers of the main organs for reproduction. That is the uterus, the cervix, the ovaries, the vagina and the vulva. So the entire gamut of these cancers are known as gynecological cancers. In addition to this, there are certain other cancers that can affect women who have finished with the pregnancy, and those are known as molar pregnancies or pregnancy-related cancers. So all this comes under the purview of gynecological cancers.
Oh, and out of these, which cancer troubles you the most?
So it's unfair to actually give them a number as which is the most troublesome to which is not, because a cancer is a cancer when it affects a person. But yes, we as gynecological oncologists and oncosurgeons are very, very worried about something like an ovarian cancer, because it is called as the most lethal cancer. And yes, that's something that we are really worried about, and predominantly because we don't really pick it up early and it's picked up a little late.
Oh, so what are the symptoms of ovarian cancer?
So unfortunately, when it comes to ovarian cancer, the symptoms are really vague. So most women would probably complain of bloating, indigestion, not really finishing their meals, feeling full very fast. And these are very vague symptoms, because, if you talk to a lot of women who are, say, in their 50s or 60s or even 40s, these are day-to-day symptoms that are going to happen to everybody on every alternate day. Correct. And even if they don't even want to then go to the doctor, you take a antacid at home, or you take some, drink some milk at night, or thanda pani, no, I need to exercise, I'm feeling bloated. So these are common misconceptions that happen. And unfortunately, ovarian cancer starts with these symptoms. And by the time they really get troubled and they go and meet a doctor, it's often pretty late in stage 3 or even stage 4 that we pick it up.
So what is the right time a woman should, do a preventive screening for these?
So first of all, coming back to ovarian cancer, let's look at it this way. There is a golden rule, or for that matter, any symptoms that anyone faces, it's called a 2-week rule. So if you've got a symptom which is not going away for 2 weeks or more, I think you need to go and see your doctor. Whether you see a family physician, whether you go and see your gynecologist, it doesn't matter, but you need to go and see a physician. As far as screening is concerned, again, unfortunately for ovarian cancer, for average women, no screening really is beneficial in picking it up early. I mean, it's proved not to be beneficial. Of course, we do recommend that everyone should have an annual health checkup where you're going to look at your bloods for sugars and thyroid, and maybe do an ECG and see that you're generally healthy. And it's a great option to do something known as an ultrasonography of the abdomen and pelvis to look at if there are anything happening there. So that's something that I would recommend everyone to do once a year, though it's not really proven to be beneficial, because you can have a normal ultrasound and 6 months later something might crop up. But even, something better than nothing, as they say.
But doctor, see, if because I talk to a lot of women, being a fat loss coach, and bloating and acidity is common to every second person. And even if they, they do go to a doctor or physician, but do you think a physician would guide them immediately to something towards a gynae cancer or something? Like, I'm just confused how to go about it, because हफ्ता अगर आप कहते हैं जैसे 2 हफ्ते अगर हम देखते हैं वो symptoms, and if I go to a physician, the first thing he is also going to write antacids and stop taking tea in the morning and all that. Then
So that is where there are, that's the catch-22 situation. There are no guidelines that tell you that itna ho gaya to iske baad inko milo, itna ho gaya to unko milo. It's kind of an awareness system where we as gynae oncologists are also making our family physician friends and our colleagues aware of this concept. That if women do come to you repeatedly with bloating, 2 weeks have gone by, at least get an ultrasound done for them and then take it from there. If your ultrasound is normal, then fair enough. You go ahead and try other forms of treatment. If you see a small cyst or something, I refer them on to your gynecologist colleague who can then take it forward from there. So I think it's more about awareness, even I would say even for women, if you're having bloating, indigestion, you feel your food you're eating, you just need to stop eating quickly. Or sometimes you start having bowel and bladder symptoms. Maybe your bowel, you start getting constipation or loose stools, and this is also not kind of stopping. Then it's a great idea to go and visit your doctor, tell them about it, or go and visit your gynecologist if you have one. So, at least they would then test you further and get somewhere. At least you've not been lax on yourself. So that's what we are looking at. Don't be lax on yourself.
so ultrasound, you say,
Yes.
an yearly ultrasound can
That
really help.
yearly ultrasound will help. And when you're talking about ovarian cancer, as far as blood tests are concerned, so there's a test known as CA-125, which is often mistaken as the test for detecting cancer. Unfortunately, it is not the test for it. Yes, of course, the raised CA-125 does tell us that there could be something cancerous happening, but it's important to remember that the CA-125 test is increased in a lot of conditions that can happen. A lot of conditions like even an infection in your abdomen, or tuberculosis, or a typhoid can increase the CA-125. If you've got large fibroids on your uterus, it can increase it. So it's not the test, but if I've got somebody who's got a very high CA-125 on their blood, I am going to investigate that person further and figure out why that's increased, and I'm not going to let it go by. So in your blood test, say, and your annual checkup, I think most women should have a CA-125 done, which more or less most packages do offer, and do a good ultrasound of the abdomen and pelvis. So at least in some way you're trying to protect yourself, or at least catching things before they really start happening.
So either a CA-125 or the ultrasound. If there's something wrong, something will come up.
Yes, or both. Something may or may not come up, but
prevention is
yes.
better. And after what age do you suggest these preventive tests should be done?
So when it comes to preventive tests, and I think if you were to talk about cervical cancer, that is where most of the preventive oncology is based on, because it's a highly preventable cancer. But if you're going back to the concept of ovarian cancer, there is no set age at which one should start doing these tests. But we say that, once you cross the age of 30, you should get yourself evaluated once. You should get yourself, at least your blood test done for sugars and thyroid and things like that. So when you're doing those tests, उसी time आपका सोनोग्राफी भी करवा लीजिए और आपका CA-125 भी करवा लीजिए. Now this is for an average woman, but there are certain groups of women in whose families we know there are cancers. For example, in your family, your mom, your aunts, your father's sisters, they've got breast cancer, or somebody's got an ovarian cancer. Then we kind of try and label these families as a genetic predisposition to these cancers. Of course, now there are tests available for that, and to test whether there is a genetic predisposition. But these are the families where the women in that family should be more careful and probably start testing themselves even earlier. But of course, nowadays we do a lot of tests for them and figure out whether they are really genetically susceptible.
Oh, so like my nani, she had breast cancer. My masi had multiple myeloma. So what test do you think I should get?
No, so the first thing is, if either of them are around still.
No, they're not.
Not, unfortunately not. So then we have today specialists known as genetic counselors. Okay. So you can actually go and meet them, tell them that this is what my family history is like. And they would then be in a position to say that, right, you are at a risk of 1, 2, 3 cancers, or you're not at a risk at all. And for these cancers, we need to check these genetic changes in your blood or your saliva or whatever. And if you find that you have that genetic change, then of course you need to look at yourself more carefully, do more tests every year, see that you're safe. For example, the commonest story that we've heard about is Angelina Jolie. Angelina Jolie is that famous American actress back in the day. So her mother had ovarian cancer, her grandmother had an ovarian or a breast cancer. So they were all tested, and they were positive for a gene known as the BRCA gene, which is a gene that promotes these cancers. A mutation in that gene promotes. So she tested herself and she realized that, oh, even I have that mutation.
Hmm.
So in a preventive fashion, she went ahead and got her ovaries removed, and she also actually got a breast removed and had implants done. So this again, this is a big topic, and maybe not the right place to discuss it, but you can do these things and you can prevent yourself. But had she not wanted to do these surgeries, then she would have had to do a regular mammography for a breast, a regular ultrasound, practically yearly, just to see that there's nothing growing in there. So then these are the kind of women who know that I have to be more careful, I have to look into things more carefully. So that is one group of women. But of course, that accounts for about less than 10% of all who are susceptible. But for majority of the women, I think a yearly annual checkup, which ways all of us should be doing. I think just add an ultrasound and a CA-125 in that.
What is the most dangerous myth about cancer that delays the diagnosis?
So the most important myth is not a medical myth. It's more of a psychological myth. It's about, it will not happen to me. That is the biggest myth that we need to take it out of our minds. Cancer can happen to anyone, everyone, and you have to be ready for it. The second most important myth is that whatever symptoms you feel, we feel that, oh, it's just a passing phase, it will go away. So, that's something that we need to remove from our minds. So for women, for example, if they have suddenly developed some form of irregular bleeding, their periods are normally regular, but suddenly they have bleeding in between periods, or suddenly one period starts getting delayed, or it comes very frequent, very fast. So a lot of women feel that, oh, this is nothing. I've been under stress, and stress can do all this, so let's leave it at that. So that's something which I don't think you should waste time on that. At least go and talk to a professional, talk to your gynecologist about it. It may be nothing, and I'm sure it's nothing, but it does no harm to go and get yourself evaluated. The third thing, it's not a myth, but the third thing is something what we call as chronic fatigue. So women in India often feel very tired, and because they're juggling 20 different things, juggling your husband, your home, your kids, your job, your in-laws, or whatever it is, and they feel tired. And at the end of the day, it's like, oh, I'm so stressed, I'm tired every day. But that's what we call as chronic fatigue. Of course, there's a mental component to that because you're doing so many things. But feeling tired and fatigued is not a great sign. You shouldn't be tired and fatigued all the time. And it's a good idea to go and get yourself evaluated. It could be as simple as a low hemoglobin and anemia, which can be corrected with iron tablets, or it could be kind of a sign of something more serious happening inside. So this is not just related to gynecological cancers, but in general. So if someone is always tired and always, chronic fatigue, I think it's a good idea to at least meet the doctor and figure out what's happening with you.
So you just mentioned about spotting and irregular periods, but today, doctor, this is a very common thing with every second female. Like either there's irregular periods or spotting in between the periods. But then, how do you decide, oh, this is a red flag, I really need to go and get my screening done or something like that?
So when it comes to, let's say for women, right? Say someone has got regular periods happening, and suddenly in one cycle you realize that you've got bleeding, your period finished, but 10 days later suddenly you've bled all of a sudden. Now, by itself is not a very, very big red flag, but it is of concern because you're not supposed to have that bleeding. So our take on that is you should go and meet your doctor immediately. A lot of people feel that, oh no, it might be a one-off and I'll wait for it. That's fair enough. I can understand that because all of us do that. We procrastinate. We kind of delay our treatment. But it may not happen in the next month. It might happen a month later, and by the time you wasted 3 months. And there could be something which is not right. So I think the very first time you feel that there's something not right, you need to go and show it. I know we are all very busy, we've got appointments, we've got life happening, and it's a pain when you have to suddenly say, oh, I got to go and meet my doctor. It's not, it's not something that was on the agenda. But I think you have to make time for yourself. The best thing that can happen to you is you go to them, they check you out, they do a few tests, everything is normal, and you then classify it as a one-off and leave it at that. But at least you're mentally relaxed that, everything's okay, nothing's wrong.
But my problem here is this has happened with me. Okay, and I'm very quick in going to the doctors because I belong to a medical family as well, and I know that small thing can be something else. This has happened with me, and I've been to a gynae, but also I feel sometimes we are snubbed by the doctors. There's nothing. Oh, you had stress, हो जाता है ये एक आध बारी चलता है. So in that situation, I want the audience also, the women also, to be more proactive, and maybe ask the doctor about getting ultrasound done, or maybe one step ahead. So how do you deal with that?
So ideally, yes. Ideally, the first line of call is an ultrasound. Now, again, when you're talking about, let's say someone has bleeding in between a cycle, how do we as a doctor, how am I evaluating that, right?
Correct.
I'm looking at your profile. So if I've got a young person coming there who's regularly has normal periods, but one off ho gaya, then we know that this could genuinely be a one-off, and we try and allay the fears and say, let me know what happens in your next cycle. But if it's an older woman who's got a family history of problems, or she's had a history of problems in the uterus in the past, and they come up with these issues, then I will get an ultrasound done immediately for her. Second thing that we are worried about is what is the nature of that bleeding. So, for example, if it's something like a post-coital bleeding, for example, she'd had intercourse with her partner, and then the bleeding has happened. That again is kind of a red flag where we need to figure out why that has happened. So in those kind of situations, it's your doctor, your gynecologist will obviously evaluate you clinically and get an ultrasound done, something like that.
So basically, as you said, that yearly screening or ultrasound is very important.
It's very important, and at this point of time, we do it as of, at that point of time, we need to get it done.
And after 25, you said that after 25, getting once a year an ultrasound is a good idea.
Yeah, 25 or even 30. Let's say 30 is a good enough age. Women in India invariably, or women otherwise, would say, I'm talking about a vast majority, who would be married before that age and probably get pregnant. They would any which ways have their ultrasounds done.
Correct.
So, but 30 is a fair enough age to start the screening process. So, so as I was just coming back to the original point, so it's not just irregular bleeding, it's the entire gamut. You look at who the person is, what the age is, what are the risk factors, what is the nature of that irregular bleeding, and then as a doctor, one makes a judgmental call, and therefore it's important to go to the right specialist. So for these kind of problems, your gynecologist is the right person to go to, and then they are the persons who would be able to tell you, right, now do this test, so this is not looking good, or this is okay, this is fine, or you need these medications.
If you had to name any one symptom that should not be ignored by a woman of any age, what would that be?
Okay, I can put that in a nutshell. It is unscheduled bleeding or irregular bleeding, whatever you call it, which means that if a woman between the ages of say 12, 13 to 47, 48 who has fairly regular periods, if there's any bleeding that is out of sync with what she's used to, that is definitely something that she cannot ignore. So that is number one. Number two is women who've had menopause. They've finished with their periods, they are 55, 60 years old, and they have even one bout of spotting or bleeding, they cannot ignore that. So all that actually comes under the heading of uncharted or unspecified bleeding, or irregular bleeding. So
that I've heard a lot actually, because I do deal with women above 45 and all, and this I've heard quite often, that I finished my periods 4 years back and now I've been bleeding so bad, and I don't think they do anything about it.
So that I think is that I think needs to change. I get a lot of patients. I've got some elderly women who come to me who are say 75 plus, and they come and they say, "Oh, doctor, I've been fine, but my daughter-in-law has brought me with me because I've had this unscheduled just one spotting. It happened last Tuesday when I was walking a lot, and then I'm fine, so I don't want to do anything about it." But we know from our books that any form of postmenopausal bleeding has to be taken seriously. You have to do an ultrasound. They might need a procedure to sample the lining, do a biopsy and see what's happening. So yes, I mean, a lot of women do ignore it, but I think it's not something that you should ignore at all.
I have a very important follow-up question because I have a teenage daughter. So what would be a pattern around periods that I should be worried for a teenager? Is there anything that we should look out for?
Oh, that's a very, very difficult question to answer, simply because this is known as menarche, the time when they start having periods, and periods can be highly, highly irregular. And it might take years for them to reach a pattern which is going to be their regular pattern. So it's very, very difficult to quantify what should be the pattern which is considered as normal, what should be abnormal. Having said that, when the bleeding is heavy and it is excessive, I think it's very intuitive for even girls and their moms to realize that, no, this is too much, my pads are getting soaked too much, I need to do something for it. And that's when they go to the doctor, and we sort of decide what we need to give them or how to evaluate them. But otherwise, if you're looking at frequency, I think there is no set pattern. So anything that is excessive and is going to be problematic and symptomatic, we consider that as a problem. For example, if a young girl starts bleeding, but every month she has 2 sets of periods happening, and it's very heavy, there are clots happening, then there is a problem. We need to deal with that. But otherwise, there is no set pattern that says that you have to get this, you have to get that. Remember, teenagers have, it's a wide spectrum. So for a girl to become a woman, it's not one particular day that she changes over. It starts at 10, 11, 12, goes on till 17, 18, maybe even more, 19, who knows. And the hormones can go up and down. The girls are going to grow, they can grow taller, broader, So many factors come into the picture. There are stresses on their minds. They're thinking about boys, about schools, about home. So there's no one pattern that fits it. But yes, when it is excessive, it is troublesome, they need to come in. Alternatively, if they just don't get period, if you've got a daughter who's 14 or 15 and she's not got her periods up till now, then that's something that you need to go and talk to your doctor about. Especially, nowadays we've seen girls getting periods a lot earlier. 10, 11, yeah. And say an average girl going to school, all her friends are menstruating. She herself will come and tell you, Mom, all my friends are getting it, but I'm not getting it. And if it goes on till she's 12 or 13 and a half, then it's a good idea to go and meet the doctor and say,
So basically, if it's not starting till the age of 13 or 14, or it's unusually heavy,
I think it's
time to
yes.
So doctor, how strong is the connection between weight, insulin resistance, PCOS and endometrial cancer risk?
Okay. So when it comes to endometrial cancer, before I begin to talk about that, let me say that it is perhaps the fastest rising cancer in India today after breast cancer. So traditionally in India, if you look at cancers in women, the number one cancer was cervical cancer, right? And breast cancer and the other cancers came much lower than that. Today, breast cancer is the number one cancer. Cervical cancer is still the second highest cancer, but incidence of cervical cancer in India is decreasing. But the cancer of the endometrium, which is the lining of the uterus, is rapidly rising. It's rising as fast as breast cancer and even more. Now, one has to remember that breast cancer, endometrial cancer, these are cancers which are driven, the origin of these cancers is driven by the environment also. So it depends a lot on your diet, it depends a lot on your lifestyle, unsaturated fats, weight gain, diabetes, blood pressure. So these are things that contribute to development of all these cancers. Now coming to your question about obesity and insulin resistance and PCOS and endometrial cancer, so that's a very complex interplay. So let me put that in the right perspective for you. So women have two main hormones, right? The estrogen and the progesterone. So what happens is, if I was to go back to the origin of the story, your periods are over, everything is done with. On that day, your estrogen and progesterone is probably at the lower end in your body. They gradually rise together over a period of the next few days. As they rise, what happens is that the uterus, the lining of the uterus starts becoming nice and thick, gets ready to have a pregnancy, if at all. At the same time as the hormones are rising, the ovary starts preparing one egg to be released, which forms a small, like a ball of fluid called as a cyst or a follicle, and the egg grows in that. At a particular time in your cycle, anywhere between day 11, 13, 14, 15, at that point of time, due to certain factors, the egg gets released. If you get pregnant in that cycle and the pregnancy goes and sits in the uterus, your hormones remain high, you don't get periods and your pregnancy grows. But let's assume, which happens normally for everyone, you don't get pregnant in that period, the egg is lost and the hormones start dropping and they come down. At some point, a period happens where all that thickened, ready uterus lining is shed off. So that is the normal process that happens in women. In certain situations, this balance between the estrogen and progesterone, which has to be in a particular format, doesn't remain so, and the activity of estrogen or the amount of estrogen becomes more. And that is the root cause where all these other problems arise from. For example, your uterine problems, which is a fibroid or a condition where the uterus becomes nice and thick called adenomyosis. This is all because of generally excess of estrogen in the system. The same estrogen also causes the lining of the uterus to get thicker and thicker and the cells in the uterus to become more abnormal and can eventually lead to cancer. So it's all related to these hormonal processes. So I'm trying to kind of put it in a nutshell. A lot of complex issues happen. So now where does obesity come into the picture here? So women who are obese, or men or whoever, the adipose cells, that is the fat cells, also tend to produce a type of estrogen. And that kind of adds on to these problems. So if you've got estrogen coming out of fat cells, you've got estrogen coming out of here and there, it's going to be on the higher side, and it's going to cause all the problems that the uterus is going to have, or it's going to cause problems with the breast. So that is where obesity kind of,
it might act as a catalyst
it
if
might,
at all you have
of
that
course,
problem.
yeah. So, and it not only acts as a catalyst, but obesity is also, it also makes things more difficult. It it kind of creates a scene where cancers can happen more easily. It creates a scene where other problems can happen. We all know that obese people are more at risk for heart disease. So it kind of, even treatment of obese people is more difficult. So that is where the adipose, the fat cells release estrogen, and that's where these cancers come into the picture here. Now, if you're talking about polycystic ovaries, right, PCOS, that's again it's a highly complicated, it's like a chicken and egg situation. Did PCOS happen first, or did obesity happen first? Nobody knows these things. But to put it in a nutshell, what happens is, remember I talked about a small cyst being formed with the egg to be released. In women with PCOS, the egg is not released. It's called a non-ovulatory or an anovulatory cycle. And the cyst remains, the egg dies in that. Next cycle, the same thing happens, the cyst happens, and they form multiple cysts. And these cysts on ultrasound appear as multiple, that is polycysts. That's how the name has been coined. Now, in these women, another point that happens is that they have something known as insulin resistance. So, again, insulin resistance is a difficult complex to explain, but if I was to break it down into very simple terms, what happens is, it's like in this condition, there is a lock on your muscles or a lock put outside on your liver, whereby the insulin cannot push glucose into the muscles and the liver. And because the glucose doesn't go into the muscles, you don't get energy for activity, right? So the body senses that, oh, the glucose is not going inside the muscle. So it pushes your body, the body produces more insulin, and more and more and more of insulin is pushed up. And the body just doesn't react to that. Therefore, it's called as insulin resistance. Yeah. So this is something that happens. In the bargain, what happens is this excess insulin also acts on the cysts in the ovary, on their lining, and makes them produce male hormones which are known as androgens. So typically in polycystic ovarian girls, they are a little bit on the obese side. They start looking, they have features like men. Blackening, darkening, hair loss, or the way they put on weight is more like a man. And even if you ask them to go and exercise a lot, sometimes it just doesn't benefit them at all. So, and then they become more obese, and that kind of adds on to the problem. So this is where the entire thing happens. So now we know that women who've got, or girls who've got PCOS and it's untreated, they're at a very high risk for endometrial cancer 20, 25 years later, simply because from that young age, they're being exposed to high amounts of estrogen. So that's a risk factor for endometrial cancer. Just like diabetes, hypertension, obesity, PCOS. So these are all risk factors for developing endometrial cancer. Now, if you listen to what I'm saying right now, this is typically a developed country problem. You've got all sorts of food, it's a relaxed lifestyle, not much of exercise, stresses and strains of day-to-day activity. People are getting a little bit bigger, more diabetes, more blood pressure. So we are getting the same cancers in large amounts as our Western counterparts had 25, 30 years back.
Correct. Makes sense.
So that's where your endometrial cancer is shooting up, your breast cancer is shooting up. So that's where it is.
So that is why, it's said so often कि भाई lifestyle ठीक रखो, work out, exercise, be active. Basically, वही, as you said, जो modern life problems हैं.
Exactly. So what are probably, I know this is a cliche statement that everyone makes, that what our grandparents and the older generation did, ate simple, lived hard, slept on time, woke up, did their work. They didn't see so many of these problems. Of course, they had different problems in their generation, but at least these problems they did not have.
But that was because of maybe less awareness and less of these medications and doctors available or whatever. But
Also, one has to understand that a lot of the cancers that happen are also a function of age. As we are living longer and we are aging more, so we are more susceptible to cancers. For example, if you look at uterine cancers, endometrial cancers. So what we talked about is a type of cancer known as a type 1 uterine cancer, endometrial cancer. There are certain less common cancers known as type 2 endometrial cancers, which are not really dependent on these factors at all. And they are very, very aggressive cancers, but they tend to happen a little later in life, little later, 70 plus, 75 plus. Uh, and there are different kinds of cancers that happen in the muscle of the uterus called sarcomas. They also tend to happen a little later in life. So they're all a function of your age. Now we can't do much about that, So
you mentioned about certain pregnancy cancers in the beginning. Tell me more about that.
right, so that's an interesting concept. So cancers that happen related to pregnancy are of two types. The first type I'll speak very quickly about is uh, if you're pregnant, there is no reason why you can't get any other cancer. So we've seen pregnant women with breast cancers, pregnant women with cervical cancers, pregnant women with different cancers. So you need to remember that just because you're pregnant doesn't mean you cannot get those cancers. And your obstetrician would evaluate you completely when you come in for a pregnancy, probably do a pap smear of the cervix also, not a mammography, but at least see that everything is okay. So that's one aspect of it. The second aspect that we need to remember is that there are certain cancers which are known as molar pregnancies or choriocarcinomas, very technical terms, but they're related to the pregnancy event. So what happens in these cancers is that you may have had a miscarriage, or you may have had an abortion, or you may even have had a normal delivery, but after that, the uterus undergoes changes inside and you develop a cancer which is related to this pregnancy. So these are known as invasive moles or choriocarcinoma, as I said. And they are a very different group of cancers. Of course, the better part about that they're well treated. There is treatment available for that, and most women do get cured of it. So that's not to be worried. But yes, that is of a concern. So a lot of people do ask me that, how do I detect that? How can that happen? Well, it's very simple. So if you say, for example, unfortunately, you had a miscarriage and you've gone to your doctor and have done a procedure and you're fine, but you continue to have bleeding and spotting for the next 2 weeks, 3 weeks, 4 weeks, you're continuing to bleed, just don't let it go by. You have to go back to the doctor so that they can actually evaluate you, check you out, and see whether you're not developing anything abnormal. Similarly, even after a normal delivery, we do know that, for the first 4 weeks or 6 weeks, you can have a little bit of spotting and bleeding. But unfortunately, if that becomes very heavy or if that continues beyond the 1 month or 6 weeks period, then I think it's important that you go and visit your obstetrician again and talk to them and say, look, this is happening to me. And they will definitely then, evaluate you, do an ultrasound, figure out what's happening and deal with that.
So baseline is anything which is happening, unscheduled or in between your month or something, that should be evaluated. It should not just be left ki theek hai, ho jata hai.
Absolutely. So any uncharted, unscheduled, irregular, call it whatever, I'm not happy with bleeding, you need to go and show your doctor.
Pap smear and HPV testing, how often should it be done and who should do it?
That's an excellent question. So to begin with, pap smears and HPV tests are tests done to detect precancerous or precancerous changes in the cervix. To go back, you have the uterus, and the lower end of the uterus is known as the cervix. And cervical problems and cervical cancers are by far the second most common cancers in India in women even today. Now, what is a pap smear test and what is an HPV test? Let's start at that point, right? So a pap smear test is where the doctor does a small scraping from the edge of the cervix, and the cells are sent for evaluation to the lab, where the pathologist and the cytotechnician takes a look at them and gives a report. The HPV test is where the same scraping is tested for the presence of a virus known as the human papilloma virus. Right? Now, the reason why we do both of these together is that we know that when it comes to cervical cancer and cervical precancerous lesions, as they say, कि cervical cancer की जो पूर्वावस्था रहती है, those conditions, majority of them are related to the presence of the HPV virus. Right? So the HPV, those women who have an HPV virus are more prone to get this. It doesn't mean that everyone who has an HPV virus is going to get it, but just that those who have persistent HPV virus are likely to, in the next 15-20 years, get these conditions. Right? So the moment you do an HPV test along with a pap smear, you read both those reports together and you know how you need to deal with these women. As far as when do you start doing this, I think 25 is the age at which it is recommended by our organizations in India. But we know that it's very difficult to get Indian women to do a pap smear and an HPV test. So we say that at least start at the age of 30. and do it as often as you can. Even twice in a lifetime is okay. So,
Oh, it should not be done every year. I've read
no,
it somewhere.
it's not. So the protocol goes like this, that if you do an HPV test and a pap smear test and both are normal, you really don't need to repeat it for 5 years.
Okay.
If you have an HPV test which is abnormal, but your pap smear test is normal, then depending on what the HPV is, the frequency of how often you need to be tested can be decided, whether it is to come yearly or too yearly, or that's how it is. Let's assume your HPV test is normal, but your pap smear shows that the cells are abnormal. Then depending upon the abnormality, one does further testing, or one does a test next year and the year after that, and so on. So there are different protocols. The idea is, depending upon your test, your doctor should be able to tell you whether you need to come next year or the year after that, or we need to do something now for you. That's how it goes.
And there are vaccines for HPV, right?
Yes. So that's another very, very important point. Today we have HPV vaccines which help you to not get the HPV virus. The thing that one needs to remember about these vaccines is that they have been initiated, say, about 15 years back all over the world, and countries are adopting it. The best time to vaccinate a young person is before they are sexually active. That is when it is most effective. And hence the rule goes that from the age of 9 onwards, you can start vaccinating girls and go on till, say, the age of 45. That's what in India we are licensed to do that. In fact, HPV vaccination is even recommended for boys now, so that they don't catch the HPV virus. So even boys as young as 9 to 15, we do recommend that you should consider taking the vaccine.
I know that because I got my both children vaccinated. I think my daughter was 10 and my son was 14.
Oh, that's fantastic.
Yes, and I also got it because the doctor recommend even you've crossed that age, but it's good to get it done.
Yes.
Because it does prevent certain strains of HPV.
Absolutely. So HPV is, there are multiple. We know more than 200 strains of HPV viruses, of which some are important in human beings, of which 13, 14 are more important in terms of disease production. And it's not just cancers, it can be vaginal warts, viral warts, vulvar warts. So just to prevent all these things, I think it's a great vaccine. And I think it should be recommended that people should definitely go ahead and take it.
So if you have teenage children, a doctor here recommends that you should get them an HPV vaccine.
So I would strongly suggest that you consider vaccination for your teenage kids. Go to your doctor and talk it out. Don't just sit at home and read about it all the time. Go and discuss it with your obstetrician and your gynecologist, and I think you need to consider taking these vaccines. It's better to visit a gynecologist now and get things sorted than many years later coming to us as gynae oncologists and deal with cancers. So it's all, prevention is always better than cure.
Another follow-up question I would have, that I read somewhere that a sexually inactive person got HPV. Is that possible?
Yes, it is possible. But, so now the HPV virus transmission is predominantly sexual. But then there are various ways in which that can happen. Even oral sex, or, you put an object inside the vagina. So a lot of things can actually push for HPV infection. So it's not just pure sexually transmitted. But yes, these things can happen.
But they're rare.
But they're very rare. Secondly, one has to remember that HPV infection is not a taboo. It can happen. It happens to everybody, practically everyone who's sexually active. Because the HPV virus is generally present everywhere. It's just that the act of intercourse pushes it towards the cervix. And in majority of the population, which is 97, 98, 99% of the population, the body's immunity will throw the HPV virus out. So it's not that it's going to remain there for lifelong.
So there's a possibility that once you are positive for HPV and
next
after 2 years you might be negative.
Negative for HPV. So that's always a possibility. So in fact, that is what will happen in majority of the people. So that is why we in fact recommend that HPV testing also we don't begin too early in life. 25, even if somebody is sexually active at the age of 18 or 19 or 20, we would say do the HPV test only after you're 25, because by that time the virus may have been thrown out, you may have immunity to it. So there are many aspects of this. And now let's look at that small cohort of people in whom the HPV remains in their bodies and doesn't go out there. A very small, insignificant percentage of them are actually going to develop problems because of HPV. You can actually live with the HPV virus within you for the rest of your life, become a great grandmother, and no one's the wiser. So it's not that virus hai to problem hai. It's not that way. Virus hai to check rakho. That's it. Just keep the virus under evaluation, keep it under check. It's not that it's going to cause problems.
So basically, I think the good idea here is कि एक हफ्ता निकाल के साल में get your screenings done, get your blood tests
Yeah.
done basic, and then you can just take care of your health according to your reports throughout the year.
Absolutely, I think so. That's the best option.
Another very viral thing that is going around internet is these raw turmeric remedies for cancer, these Ayurvedic remedies for cancer, and I, as a layman, am also sick and tired of hearing these things that ये हल्दी खाओ कैंसर चला जाएगा, ये पानी पियो कैंसर क्योर हो जाएगा. Can you please throw some light on that?
Okay, so turmeric and haldi are very traditional Indian food items and things that are there. So it's important to remember that they have multiple chemicals within them. One of the chemicals that they have is a chemical called curcumin or curcumin, the way you pronounce it. Now, this is known to have antioxidant, anti-inflammatory properties. The question here is that, and yes, of course, it might be helpful at some level. It is just that from our allopathic standpoint, there is no documentation that tells us that you need to take this much in this quantity at this point of time for this condition. And therefore, it's very difficult for us, even from a very legal and a medico-legal standpoint, to tell a patient that, oh, no, you take this only and this is going to help you. It's not something that we can do, I would do, most probably. So my take on these would be, yes, it may be helpful, but if you've got a particular condition, if you want to, say, treat yourself, I think you need to take the standard treatment first. You come to the doctor, you come to us as oncologists, let us treat you with whether it is surgery, whether it's chemotherapy, whether it's radiation. You can definitely try these remedies, and we are not the experts on that any which ways, as a supportive treatment, which helps you deal with these cancer treatments better, maybe help you deal with pain better, or things like that. But there is no level 1 evidence in our allopathy that actually tells us that this is going to be 100% beneficial for this and you have to give it in this dosage. If it was, then we would definitely be utilizing it. That's where we come from. So my message for people is that, well, don't neglect your standard treatments. You can utilize these treatments, you can go to the experts, you can talk to them about it, take something. But, just doing haldi ka doodh and turmeric for treating cancer, I don't think that's a great strategy in life. I mean,
as an oncologist, have you ever seen a first-hand case where a patient opted only for Ayurvedic care and then worsened their condition and came back to you?
So unfortunately, we do get such situations where we've had patients with, say, an ovarian tumor who've refused to do surgery for whatever reasons, and they've gone back and they've taken alternative therapies, but come back 6 months later because the condition is worsened. So it can happen. It can definitely happen. So, there is a logic behind it. The specialist with the other treatments would say that, oh, it was a bad cancer, it was going to grow anyway, irrespective of your treatment. That may be the case, but, I would definitely say that you try what is tried and tested first, which is there where there's evidence for that. And then, if not, you can always look at these therapies after that.
I am appalled by the number of people who talk on podcast and Instagram and YouTube about, and if you vet them, if you see their degrees, they are just a PGD. They're just a diploma in whatsoever, and they are blatantly giving out advices around cancer treatments, cancer diets, and I feel that's very irresponsible. And that's the entire point that I wanted a medical professional here who's an oncologist, because this needs to be said. You can't come out being so irresponsible and just telling people कि सब कुछ छोड़ दो और हल्दी और दूध और ये सब पियो. ठीक है, वो पियो as you said, but in support with your allopathic therapy or your medications.
Absolutely. So in fact, I am aware of very, very good Ayurvedic doctors who are extremely knowledgeable and know their science and know everything very well. And more often than not, they will always tell a patient that, listen, for this kind of a condition, you need allopathic treatment. You go and do this. I can support you in this format. I can give you these kind of Ayurvedic medications. So the best results are always going to be when things go hand in hand rather than in exclusivity. It is just that, from our point of view, because as an allopath, we study allopathic medicine, we know the scientific reasoning and the evidence behind it. We talk of level 1 evidence, level 2 evidence, level 3. So where we have level 1 evidence over the years with trials and this, that, and the other, that there are certain treatments that are going to work for certain cancers. We do that. Now, unfortunately, cancer is a very difficult disease to treat, and sometimes things don't work, or if the patient comes in an advanced stage, it may not work. But I would most definitely say that go for the standardized treatment first. And always, these Ayurvedic, homeopathic, they're damn good and they're available, but maybe you can use them as an adjunct or as a help rather than considering them as the primary form of treatment.
So I've heard this that cancer has a cure, but the pharma industry doesn't want it to be out, or it's like they don't want it to be out because it's a huge, the cancer medication industry is huge. So as a doctor, as a medical student, what would you say about it? Like, you studied the ins and outs of the cancer and everything.
I think that, well, I think that's a very simplistic statement to make. It is not like that. There are certain cancers that are definitely curable, and the cure is out for them at a certain stage, a certain type. But then, means if I was a pharma industry guy and if I had a cure that could cure a certain stage cancer at a certain time, I would definitely put that medicine out there. Naturally, it's going to help people. So I think maybe that's a very simplistic statement to make. I think from our standpoint, there are certain cancers, when you catch them at certain stages, certain types of cancers, you can cure them, you can treat them, and cure is there. And then there are certain other cancers which are maybe some advanced stages, certain types of cancers where there are expensive drugs available, they help in controlling the cancers, but they may not cure them. So, I think that is where we stand. I don't think anyone is hiding a drug. Nobody is hiding a drug.
That's good and assuring to
Yeah.
hear from a medical doctor.
There are a lot of drugs that are there in the pipeline which are undergoing testing. And of course, even from the pharma standpoint, they have to be very careful before they put out a drug. It has to be safe, it has to be tested. And that takes a lot of time to do that. So we keep hearing in papers there is a cure for this. Now, that's like a filtered statement, where the pharma industry has probably put out a nice big article saying that in this stage, if you do this, this might be beneficial. And somebody just takes that into one sentence and says there's a cure. So it doesn't work that simply. So
yeah, maybe I think there are multiple layers to it.
Multiple layers to it, yeah.
Any particular lifestyle habit you would say that quietly increases a woman's risk of cancer?
So when it comes to gynecological cancers, there are two types of lifestyles that are not that great. So if you're looking at the traditional cervical cancer, so we were always taught, that women who get married early, who have multiple children, for them the risk of cervical cancer is worse. Women who have multiple sexual partners, for them the risk of cervical cancer is worse. So that is one aspect of it, and which I think is an educational thing where you talk, teach, and girls and women come to know about that. Society as a whole will kind of curb that.
Any recent advances in treatment give you the most hope for women who have gynae cancers?
Yes, in fact, this is where there are two types of. So if you look at cancers in women, right, they're treated in gynecological cancers. There are three types of treatments that I spoke of. One is surgery, one is radiation, and one is the drugs, that is medical oncology. So if you start with medical oncology, there are huge advances that are happening today. There are a huge number of drugs that are available or coming into the market or under research. Drugs which are known as immunotherapy drugs. Soon there'll be drugs that target your genes. So there is a lot in the pipeline that is happening, and it's likely to benefit us. Of course, as I said, these drugs are going to come out slowly and steadily after rigorous testing, but it's a very, very exciting field, especially with gene therapy opening up. There's a lot of potential for treating women cancers which were earlier considered absolutely untreatable. So, we are really looking forward for these things to happen. The next form of treatment is obviously radiation therapy, which is basically giving high dose X-ray radiation to cure the cancers. Again, today's machines are getting better, they're getting smarter, they're utilizing AI, they're utilizing MRIs and computer aided formats. So yes, we are treating a lot more cancers with these things. And of course, when it comes to my field of surgery, we've really gone a long way in the last 10 years itself. We've got minimal access surgery with 3D systems coming up. There is robotic surgery coming up. So, things which are very difficult to operate earlier with open surgery are becoming better and better with robotic surgery, or even vice versa. Even open surgery, the standard operating routes are getting safer. So these are all there. So we are doing better. There's no question about that.
This is another myth, and I suddenly remembered it because this is like a first-hand account. I went to a gynae, and this was the doctor's word. So I really want to, since you're an oncologist, I really want to clear this myth. I heard that mammograms give you a, mammograms make you more prone to get a breast cancer, and this I've heard from a doctor.
So,
She said ki because mammograms, they press the breasts and these cells are activated. These were the words.
so in fact, there was somebody who once recently, I don't remember the person who came on TV and said that they don't do mammograms and they're more dangerous for the body. And I think that's a complete myth. I think mammography is the best thing that you can do to keep your breast under check. And we're not doing a mammography every day. You're technically a mammography should be done once in 2 years. So if you do a mammography and it's normal, the recommendation is do it once after 2 years. So getting that kind of pressure in your breast or getting that kind of X-ray radiation is very, very minimal. The background radiation risk is more. If you're walking around the streets of Mumbai and there are 4 towers and you're walking around there, you're exposed to way more radiation than your mammography anyways. So I don't think that's the right attitude. I think people have to be wiser about it. They need to read up a little bit about it. And these are tried and tested therapies. They're tried and tested prevention protocols all over the world. Today's mammography is so good and so sensitive. They pick up very, very early cancers, which are so easily curable, and you're cured for life. So I think whoever said that probably is not well read enough for that.
But I really think now the government or something should make a body for people like these who just comment things which does more harm than good. Imagine the number of people that must have heard that statement and must have chosen not to get the test done.
Absolutely, I completely agree with you. But unfortunately, there are people out there who make these statements and people listen to them. But yeah, I think education through mediums like this is what people need to hear and tell their people. So what happens is a lot of these folks who come from slightly uneducated backgrounds or low socioeconomic strata, they don't know the facts of it. So I keep telling my patients also that you tell your house helps, you tell your drivers, you tell their wives, you spread awareness at your own level.
Correct.
It's one thing patients coming to me and I will tell them, but आपके घर में है, so many people are working with you, so you can always tell them and they're going to trust you. Your maid is going to trust you more than somebody else telling you something else.
Correct.
It's
No,
that way.
that is absolutely, that makes sense, and that's something I follow as well.
Absolutely.
So one symptom women should stop Googling and start getting medically checked.
Oh, I think the most important symptom is two. I would rather say one is irregular bleeding, which we've spoken of, and any form of irregular bleeding. And second is a vaginal discharge. So, I wanted to talk a little bit about vaginal discharge. So, if a woman has excessive vaginal discharge, which is whitish or smelly or yellowish or reddish, I think instead of Googling about it, can it be normal, can it be okay, I think they should get themselves checked out. That's extremely, extremely important for that. Having said that, we do know that there are certain women on this planet who generally have a slightly higher vaginal output, but then their discharge is different. Their discharge is more clear. It is non-smelly, non-foul smelling. They don't have pain. But it's always worthwhile to go to a doctor and figure it out. Is that a normal discharge or abnormal discharge? So those are two things that I think women should not really bother about Googling too much. A lot of women come to me or come to my colleagues, to gynecologists, and say that, I've been having discharge. I took antifungal treatment because I've read that it could be a fungal infection, but it's not going. So, they wasted their time in doing all that.
So that could be a symptom of what?
It could be it could be something different. Like it could be a bacterial infection, or it could be something more dangerous as a growth on the cervix. It could be anything, but it's better to get checked, treated, and just do it once and for all rather than at it again and again and again. So
one test for women above 35 that they should be postponing.
In a nutshell, it is a pap smear test. You should not postpone your pap smear and HPV test. At 35, if you've not done it, please do it.
One message about women's health you wish every woman would hear and remember.
So one message that I can give you, which is a very generic message, is do not neglect your bodies. If you're suffering from a problem inside, your body will let you know. You will come to know that you're not feeling well. You will have that irregular bleeding. You will have that weight loss. You will have that not feeling good after eating food. Do not neglect yourselves.
Does a pap smear test screen for all types of gynecological cancers?
Unfortunately not. A pap smear test is only for cervical problems.
Are gynecological cancers only a concern for older or postmenopausal women?
No, gynecological cancers can happen at any age group. In fact, even young girls can have ovarian tumors and they can have problems. But predominantly, it's for perimenopausal women. But gynecological cancers can happen at any age.
Do gynae cancers show no symptoms until it is too late? The silent killer myth?
Uh, some cancers, yes. For example, an ovarian cancer is called as a silent killer because you don't have particular symptoms for it. But for other cancers, yes, you have symptoms: irregular bleeding, postmenopausal bleeding, excessive persistent discharge, but change in bowel bladder habits. I think there are potent signs of cancers, or at least potent signs that tell you to get yourself checked out.
Can I still get a gynae cancer if I've had a hysterectomy?
So if you had a hysterectomy, obviously you can't get the cancer of the uterus. But if your ovaries have been kept inside, yes, you can get ovarian cancer. There is another cancer which is known as a primary peritoneal cancer, which behaves like an ovarian cancer, and that's something that you can get even if your uterus and ovaries are out. But these are very, very rare situations.
Am I only at risk if I have a family history of these cancers?
If you have a family history of these cancers, you are at a higher risk, but otherwise, every person, every woman is at risk.
If I have been vaccinated against HPV, can I stop getting cervical screenings?
No, that's a myth. I think if you've been vaccinated for the HPV vaccine, you still need to go for your screening regularly.
Do birth control pills increase my risk of developing gynae cancers?
Birth control pills will actually reduce your risk of getting ovarian and endometrial cancer. So they are quite useful. Of course, the primary idea of giving birth control pills is for birth control.
Does using talcum powder on the genital area causes ovarian cancer?
So talcum powder is known to slightly increase the risk of getting ovarian cancer, but it is not even half as important as many of the factors that we've spoken of.
Is abnormal or postmenopausal bleeding just a normal part of aging?
It could be a normal part of aging, but every postmenopausal bleeding or abnormal bleeding has to be evaluated. You rule out the presence of a disease and then say it's a normal part of aging.
Does a regular physical pelvic exam always detect ovarian cancer?
Unfortunately not. So regular pelvic exam may or may not detect ovarian cancer. In fact, regular screening with ultrasound and CA-125 may or may not also detect it. But you should still go and get yourself evaluated.
Does having an IUD increase the risk of uterine cancer?
No, it does not increase the risk of uterine cancer.
Is cervical cancer the only gynae cancer I need to worry about if my pap test is normal?
No, if your pap test is normal, you're still at risk of getting uterine cancer, endometrial cancer, ovarian cancer. So those pap tests do not pick up those cancers at all.
This has been a very insightful episode, doctor, and thank you for clearing so many myths around gynae cancers. And I myself, I'm being into social media and everything, I don't think I've heard about these cancers a lot. This is the first time I'm hearing in depth about these cancers. Thank you so much for taking out time for doing this, and it has been really a pleasure.
Thank you for having me here. Thank you very much.
Do share this with other women in your life, and also please take note if you have a teenage daughter. Don't forget to subscribe. Bye bye.